I want you to imagine that you're sitting in a school building on just a random weekday.
Right, just a normal day.
Yeah, exactly. And suddenly the fire alarm starts blaring.
Oh, wow.
The strobe lights are flashing, the siren is totally deafening, and like you can actually smell smoke.
Okay, so a real
A
emergency.
real emergency. But instead of the staff calmly directing everyone out of the clearly marked emergency exits, the people in charge they point to a massive, dusty three-ring binder sitting on a shelf.
Let me guess, it says fire safety policy on the spine.
Yep, that's exactly it. And you would probably think, well, it's wonderful that we have a policy, but the building is actively on fire.
I mean, that is just the ultimate false sense of security, right?
It really is.
And unfortunately, that exact dynamic, having this beautiful plan on paper that entirely falls apart in a real-world emergency, that's something we see playing out right now in incredibly high-stakes environments.
Yeah, which brings us to the core mission of today's deep dive for you listening. We are unpacking the massive and frankly often dangerous gap between what experts call paper compliance and actual functional clinical capacity.
Specifically in K-12 school mental health.
Right. And to do this, we're analyzing source materials from MentalSpace School, which is an organization that provides mental health support designed specifically for school districts in Georgia.
And the distinction between those two terms, paper compliance versus clinical capacity, it's everything.
It's the whole ball game.
Yeah. Paper compliance basically means you've checked a box. Like a perfectly formatted binder might satisfy a district auditor who walks through the building once a year.
Sure, it looks great on a desk.
Right. But a binder cannot de-escalate a teenager who is actively in the middle of a severe psychiatric crisis. Clinical capacity means you actually have the resources, the personnel, and the logistics to handle that crisis the moment it occurs.
To put it another way, paper compliance is like reading a really comprehensive, peer-reviewed manual on how to swim.
Okay, I like that.
Like you understand the theory of buoyancy, you've memorized the mechanics of the front crawl, you can even pass a written test on water safety.
Well, you're not actually in the water.
Exactly, functional clinical capacity. That is having a trained, physically present lifeguard on duty, holding a life preserver when you are unexpectedly thrown into the deep end of the pool.
I love that analogy because it perfectly illustrates the urgency of it all.
Yeah.
Because in a K-12 environment, when a student experiences a severe mental health crisis, theory just goes out the window instantly.
You're in the deep end right then.
You're in the deep end. You need a mechanism to pull that student out of the water right then and there.
So let's ground this in the real world with what the sources refer to as the 9 a.m. on a Tuesday stress test.
Yes, this is such a crucial concept.
Because this is where we move completely away from the theoretical policies and look at the physical reality of a typical school day.
Right. The stress test poses this highly practical scenario to Georgia school leaders, and honestly, it exposes the cracks in a system almost immediately.
Like within minutes, really.
Exactly. The question is just this. If a student presents in an acute mental health crisis at 9:00 a.m. on a Tuesday, what actually happens in that building over the next 4 hours?
And we should probably paint a picture of what that actually looks like for you. It's 9:00 a.m., first period is well underway.
The halls are clear.
Yeah. And a sophomore walks into the busy front office having a severe panic attack, or perhaps they just confided in a teacher that they're experiencing suicidal ideation.
The clock starts ticking right then,
Yeah.
minute by minute.
Right.
So the stress test asks, does a licensed specialized clinician see that student before lunch?
And what's the usual answer?
Well, for a staggering number of school districts, the uncomfortable but honest reality is that it would take days, if not weeks.
Wow.
Yeah. If the front office's response protocol basically consists of handing the parents a referral list of outside community providers, or maybe placing the student on a massive external wait list, that school has completely failed the stress test.
So they have a paper trail, but zero clinical capacity.
Exactly.
I think a lot of people listening might be a little confused by that because my immediate thought, and probably yours too, is don't all public schools have guidance counselors on staff specifically for this?
That is the assumption, yeah.
Right. I mean, if there is a counselor sitting in an office down the hall, why on earth would it take days to get a student in crisis in front of a professional?
It's probably the single most common misconception about how schools operate today. We really have to look at the harsh mathematical reality of K-12 staffing.
The ratios.
The ratios. The counselor-to-student ratios across many districts in Georgia and frankly nationwide are just astronomical.
What are we talking, like a couple 100 to 1?
Higher. A single school counselor might be responsible for a caseload of 400, 500, sometimes even 600 students.
600 students for one counselor. That is just an unbelievable bottleneck.
It is, and you have to factor in what that counselor's daily schedule actually entails. They are not just sitting around waiting for a crisis.
Right, they have actual daily tasks.
A lot of them.
Yeah.
They're managing severe scheduling conflicts, conducting academic advising, mediating peer disputes, running IEP meetings for special education compliance.
Wow.
And often they're covering lunch or bus duty on top of it all. They are constantly in motion.
So if our hypothetical sophomore walks in at 9:00 a.m. in crisis,
The on-staff counselor physically cannot drop their entire mandated schedule to spend 3 uninterrupted hours de-escalating a severe psychiatric event.
they just don't have the time.
They don't.
Oh.
And even if they somehow manage to do that on Tuesday morning, an acute crisis requires ongoing specialized clinical therapy.
Like weekly sessions.
Yeah, maybe an hour a week for the next 6 months for that student to actually heal.
Well, and if the school counselor blocks out an hour a week for intensive trauma therapy with one student, the other, 499 kids on their caseload lose their academic and behavioral support?
Exactly. It's a zero-sum game.
Yeah, that makes sense.
School counselors are vital, incredible professionals holding the educational ecosystem together. But their structural role is general well-being, academic guidance, and baseline behavioral support.
They're not a hospital wing.
Right. They simply do not have the bandwidth, and sometimes not the specific psychiatric specialization, to act as a dedicated long-term clinical trauma team. Expecting them to do so is a recipe for catastrophic burnout.
Okay, so handing a family a community referral list is a failing grade.
Yes.
And relying solely on an overloaded internal guidance counselor is also a failing grade on this stress test.
Unfortunately, yes. Because the wait time for meaningful clinical intervention is still measured in days. And for a teenager in profound distress, a few days can be a matter of life and death.
Which forces us to define what a passing grade actually looks like, right?
Yeah, we have to look at the solutions.
The sources outline 3 non-negotiable pillars of true functional readiness. And the very first requirement is having a named, dedicated clinical team attached directly to that specific school building.
I'm glad you emphasized named. Because there is a massive difference between a generic resource and a named resource.
Let's dig into that. What does that mean in practice?
Well, a generic resource is basically an employee assistance program model. It's like a 1-800 number you call where you get whoever happens to be on shift at a remote call center.
Oh, okay. So it's totally random.
Totally random. But a named team means the principal, the teachers, the front office staff, they know exactly who their clinicians are.
Like, it's Sarah or David.
Exactly. It's Sarah or David, and they are assigned to that specific campus. That builds crucial continuity.
So they're part of the community, basically.
Yeah. When a crisis happens, the school isn't reaching out to avoid. They're activating a known partner who already understands the culture and the specific demographics of that school.
So you are bypassing that entire getting to know you phase in the middle of an emergency.
Exactly. You skip right to the intervention. Now, the second pillar is same-day access for urgent presentations.
So no wait lists.
No wait lists. If our student presents at 9:00 a.m., the protocol cannot be, well, let's look at the calendar and see if we can squeeze them in next Thursday.
Because next Thursday is too late.
Way too late. It must be same-day access to a licensed professional. And then the third pillar demands response protocols that the physical staff in the building have actually been rigorously trained on.
And that they can execute under pressure without hesitation.
Right.
You know, the timing of all this seems incredibly tricky to me. The sources point out that schools usually realize they lack these 3 pillars at a very specific time of year.
Yes, and it's not when most people think.
Right. You would think the big crises happen in the dead of winter, like during midterms or finals, but the data... Why the beginning of the year?
Think about what happens over a summer break. Students are away from the structure and the visibility of the classroom for months.
Yeah, they're off the radar.
Right. And many of them experience unaddressed trauma, maybe food insecurity, shifting family dynamics, or just severe anxiety during that time.
So it all builds up over the summer.
Exactly. And when August rolls around, they bring all of that directly back into the classroom on day 1.
Oh, wow. So the teachers are suddenly dealing with 3 months of pent-up issues all at once.
Instantly. The system gets heavily stressed immediately. The gap between that dusty binder and actual clinical capacity becomes glaringly visible within the first 2 weeks of the semester.
Which is why you can't wait until the crisis happens to make a plan.
Exactly. Functional readiness requires the safety net to be fully constructed, funded, and tested before the first bell even rings. You cannot figure out your crisis protocol while a student is actively deteriorating in the hallway.
Okay, so we've established the mechanics of the problem and, the theory of the solution. Let's look at how this is actually executed on the ground.
Yeah, let's get into the practical side.
This is where MentalSpace School comes in, right? They're partnering with these districts in Georgia to provide these exact pillars we just talked about.
They are. MentalSpace operates by providing a comprehensive suite of services that integrate directly with the district.
So they're not a separate entity acting in a silo.
No, they act as an extension of the school. They assign those dedicated, named therapist teams to individual schools. They handle suicide and violence prevention protocols.
Right.
But their defining feature, the thing that really allows them to pass that 9 a.m. stress test, is their capacity for same-day teletherapy.
Okay, I have to pause you there and actually push back on this a bit.
Sure.
Because I'm having a really hard time visualizing the teletherapy aspect during a severe acute crisis.
I hear that a lot, actually.
I mean, I understand that video calls remove geographic barriers, which is amazing for rural districts. But if a teenager is highly dysregulated, like maybe they are throwing things, maybe they're a physical danger to themselves, or others putting an iPad or a laptop in front of them, feels incredibly counterintuitive.
Yeah, seems like the last thing you'd want to do.
Exactly. How does a clinician on a screen manage the physical reality of a chaotic room?
It is a really vital question. And honestly, it highlights a major misunderstanding of how integrated telehealth actually functions in an emergency.
Walk me through it.
The key here is that MentalSpace is not replacing the adults in the building. They're partnering with them to split the burden of the crisis into two very distinct parts.
Two parts. What are they?
Physical safety, exactly. So they might clear the other students from the classroom. They ensure the environment is physically safe. They remove dangerous objects.
So they are managing the room.
Right. They are the hands-on presence managing the physical space.
They are doing what they are best positioned to do, which is securing the immediate environment.
Yes. But once the room is physically secure, those educators are not psychiatric experts.
Right, they're teachers.
Exactly. That is when the external clinical team at MentalSpace is brought in via the screen.
Ah, okay. Once things are physically contained.
Yes. The clinician takes over the psychological de-escalation because they have the specialized training to talk the student down, to assess the immediate psychiatric risk and begin triage.
I see. So the adults in the room provide the physical container, and the clinician on the screen provides the specialized medical intervention.
It is a highly coordinated dual-layer approach. The teletherapy provides the psychiatric expertise, instantly bridging that gap that normally takes days while the school staff maintains environmental control.
You absolutely need both layers functioning together for the model to hold up under pressure.
Without a doubt.
And the sources mention that MentalSpace doesn't just focus on the student in a vacuum, right? Their model extends out to include staff wellness programs and even family counseling.
Which is absolutely essential, because treating a student for 45 minutes a week is ultimately futile if you just send them right back into a deeply dysregulated environment.
Right. If the whole house is on fire, you can't just fix one room.
Exactly. If the parents are navigating an intense crisis at home, or, if the teachers are so profoundly burnt out that they are projecting stress into the classroom, the student's progress will just stall.
You have to treat the entire ecosystem around the child to achieve sustainable, functional readiness.
Exactly. It's a holistic approach.
Well, the clinical model makes total sense. But whenever you try to combine the public education system with the healthcare system, especially when you're involving minors,
Oh, here we go.
you are guaranteed to run headfirst into a massive wall of bureaucracy.
It is unavoidable.
Even the best clinical model in the world will die on the vine if the administrative red tape isn't handled.
Oh, the logistics of documentation and the realities of insurance billing are the silent killers of functional capacity.
The silent killer.
Yeah. If a district cannot navigate those two things, the clinical care never actually reaches the student.
Okay, let's unpack the documentation nightmare first. The sources highlight the collision between HIPAA and FERPA.
This is a big one.
And for anyone listening who hasn't worked in administration, dealing with HIPAA and FERPA simultaneously sounds like trying to get two highly secure bank vaults to talk to each other when they use completely different encryption keys.
That is the perfect way to describe it. It is famously difficult.
It's a jurisdictional nightmare.
It really is. Because FERPA is the federal law that governs educational privacy. So it
Mm.
protects things like a student's math grades, attendance records, and their behavioral disciplinary files,
Right, the school stuff.
the school stuff. But HIPAA is the federal law that governs medical and psychiatric privacy.
So when a student receives medical therapy inside an educational building, those two massive regulatory frameworks basically just crash into each other.
Exactly. A school counselor cannot legally just pull a student's external psychiatric diagnosis chart.
No, of course not.
And an external medical therapist cannot simply log into the school's server to check the student's disciplinary history, not without navigating a massive maze of consent forms and waivers.
Which takes time you don't have in a crisis.
Exactly. And most school administrators do not have the time or the specialized legal knowledge to constantly untangle that web.
So what does MentalSpace do about it?
MentalSpace assumes that burden. They handle the documentation architecture to ensure all data sharing is completely compliant with both sets of laws,
Oh, wow.
and they do it without dumping a massive new administrative workload onto the school's front office.
Which frees up the educators to actually educate rather than acting as like privacy compliance officers?
Exactly. Let the teachers teach.
Speaking of compliance, the sources also note that MentalSpace supports districts in preparing for something called HB 268 in Georgia.
Yes, HB 268.
Now, just to frame this for you listening, regardless of the politics or the debates surrounding any specific state legislation like HB 268, the reality on the ground is that school districts are legally obligated to figure out how to comply with it.
They don't have a choice.
Right. They have to produce the reports, implement the mandated protocols, and basically prove they're following the law. And of course, if you're working in a district, you must consult your own legal counsel for statutory interpretation. But the source material emphasizes that this practice provides the structural and administrative support to help districts meet those newly legislated requirements.
Right. It's about removing the operational friction so the school can stay compliant and focus on the students. HB 268 sets new, specific statutory requirements for how Georgia schools handle student mental health, safety plans, and crisis interventions.
Okay, so they handle the administrative friction. But if we move from the administrative friction to the financial friction, we hit the single biggest threat to this entire system.
The payer model.
Exactly. How does the therapy actually get funded?
This is usually where the wheels completely fall off.
The sources detail a very specific financial structure for MentalSpace. They handle all the billing, but crucially, they bill Medicaid at $0 to the families.
$0. That is massive.
And on top of that, they are in-network with a massive roster of major providers. We're talking Blue Cross, Blue Shield, Cigna, Aetna, United Healthcare, Humana, Peach State, CareSource, and Amerigroup.
That is a huge list, and we really need to look closely at the why behind that massive list.
Yeah, let's get into it.
Why is a broad, zero-barrier payer model the absolute linchpin of functional readiness?
Well, primarily because school districts are not designed to be medical billing departments chasing down copays from parents.
That's true, but more importantly, think about the family. Imagine a school has done everything perfectly. They passed the stress test. It's 9:00 a.m. on the Tuesday. The student is in crisis.
The physical room is secure.
Yes. The dedicated, named therapist is ready on the screen to provide immediate triage.
The system is working flawlessly.
But then the logistical reality hits. The family is contacted, and they discover that the provider's out of network,
Oh, no.
or that their specific insurance plan requires a massive $75 copay per session.
Yeah, that's a lot of money for an unexpected bill.
For a family already struggling with inflation and housing costs, that financial barrier is just insurmountable.
They have to make an impossible choice right there on the spot.
They look at that cost, and they are forced to say, we cannot afford this care. We have to decline the therapy.
Wow.
And in that exact fraction of a second, despite all the brilliant planning, the trained staff, the amazing technology, the school's functional readiness drops instantly back to zero.
Because the mechanism failed. The lifeguard was on duty, the life preserver was in their hands, but they couldn't throw it because the drowning person couldn't produce a credit card.
That is exactly what happens.
Yeah.
A system is only as functionally ready as its ultimate accessibility.
Right. If you can't access it, it doesn't exist.
If the care is too expensive to access, it does not matter that the clinician is sitting on the screen ready to go.
So how does MentalSpace solve that?
By ensuring that Medicaid is billed at $0 to the families, and by doing the exhausting back-end work to accept virtually every major commercial insurance carrier in the state.
They eliminate the financial bottleneck.
Exactly. They ensure that when the clinician is needed, the therapy actually happens.
It has to be a zero-barrier system from start to finish, or, like we said at the beginning, it's just another dusty binder on the shelf.
It really is.
Well, we've covered a tremendous amount of ground today, unpacking the invisible architecture of K-12 mental health. Let's just briefly recap this journey for you listening.
Yeah, let's bring it all together.
We started by dismantling the illusion of paper compliance, proving that having a policy is definitely not the same as having a solution.
And then we applied that 9 a.m. Tuesday stress test,
Yeah.
which revealed the harsh reality that relying on external referral wait lists or, mathematically overloaded guidance counselors, it completely fails to provide the immediate, specialized clinical capacity that an active crisis demands.
From there, we explored the mechanics of true functional readiness. You need named teams, same-day access, and executable physical protocols.
And we looked at how MentalSpace School actually implements this in Georgia through a dual-layer teletherapy model that partners the physical adults in the room with those specialized clinicians on a screen.
And finally, we examined the absolute necessity of navigating the red tape, right? Bridging the HIPAA and FERPA divide and establishing a zero-barrier payer model that prevents those copays from vetoing critical care.
Because without that, none of the rest of it matters.
Exactly. Now, why does all of this granular detail matter to you? Well, whether you're a teacher standing at the front of a classroom, a parent watching your kid get on the bus, or simply a taxpayer living and working in a community, the mental health infrastructure of your local schools dictates the safety, stability, and really the future of that community.
It impacts everyone.
It does. When a school achieves true functional readiness, crises are de-escalated safely, students actually heal, and the entire educational ecosystem thrives.
MentalSpace School outlines a highly integrated zero-barrier system designed to catch K-12 students the exact moment they fall.
Yeah.
But, looking at the sheer efficiency of this model leaves us with a fascinating and maybe a slightly unsettling question for you to ponder.
Okay, where does this lead us outside the school walls?
Well, we clearly possess the technology, right? We have the clinical partnership models, and we have the administrative frameworks to provide immediate, same-day, no-barrier crisis intervention for children in a school building.
Right, the blueprint absolutely exists. We just talked about it.
Yeah, exactly. So why is it so incredibly difficult for adults to access this exact same level of seamless, immediate mental health care in their workplaces, their community centers, or their local clinics?
Oh, wow, that is a profound contradiction.
Isn't it?
We build these comprehensive zero-barrier safety nets for our kids, but the moment they graduate into adulthood, that safety net entirely vanishes, and they are handed a referral list and a massive copay.
It really forces us to ask why we tolerate a lower standard of functional readiness in our adult healthcare infrastructure than we demand for our schools.
Something to definitely mull over as you look at the systems around you, because regardless of your age, your profession, or where you happen to be sitting, when the fire alarm goes off in your life, you don't want someone pointing to a policy binder.
No, you definitely don't.
You want the emergency exit to be clear, open, and ready to use. Thanks for joining us on this deep dive.